angina. So this is very hygiene topic. Okay. So first see the difference. What is the difference between angina and MI? Myocardial infarction is like death of cell. Infarction is death of cell. So here you will have increased level of troponin. Okay. So when the word MI is given, it means you are having death of cell. Troponin level will be raised. Okay. If angina is given, no matter which type, here you will not have death of cell. Troponin level will be normal in angina. Okay, here you can see, I will clear that. Here you can see, okay, here you can see no infarction in both of them, no elevation of troponin. But these MI, okay, here you are having infarction. Okay, actually there will be difference between unstemy and stemy we'll cover later, but first focus on troponin and infarction. In MI, you will have more troponin level, you will have infarction. Okay, let's start from here. Here, chest pain due to ischemic myocardium. Okay, so ischemic myocardium pain will be actually like that, dull pain, radiating to some. Okay, so what is the three important point for classic angina? Okay, this is important. Classic inginal pain. First pain is dull. Okay, okay. Then second is increased by exertion. Third point is decreased by rest or nitroglycerin. So this is called typical anginal pain. It will be common in male. If 30-year female come with chest pain, okay, remember this pain will be atypical anginal pain because this type of pain in female angina is not common. Actually, post-menopausal female is have common MI, but pre-menopausal female have less chances of MI. So, if young female come with chest pain, that is called atypical angina. Okay, but if male come with typical anginal pain, you will you will definitely go toward actually ECG. But if female have these symptoms, you will not do ECG. You will just do, okay. You will just reassure the female like that. Okay. So now there are three types: stable, vasospastic, and unstable. Stable angina. Okay. Again, angina, no troponin elevation, no infarction. Okay. Stable angina will resolve with rest at nitroglycerin. Unstable angina will occur even at rest. So that is different, stable and unstable. That's it. We have covered. Okay, stable, it is more due to when occlusion will be more than 70%. Okay, remember, if 60% occlusion is given, you will not have angina. If 50% is given, you will not have angina. Okay, more than 70. Okay, you will have exertional chest pain in classic distribution. So in this type of angina, you will have ST depression on the ECG because whenever you will have complete occlusion, then you will have a STEMI. Otherwise, you will have ST depression. Resolved with rest or nitroglycerin. This is important. Next, I will move toward the unstable angina. Unstable angina, okay, you will have thrombosis, okay, with incomplete coronary artery occlusion. It is more than 70, but it is less than 100. Remember, unstable occlusion is more than 70, but more than stable angina, but less than MI. Okay, because in MI you will have complete occlusion. Here you will have incomplete occlusion. Here you can develop ST depression or T wave inversion, but troponin will be normal. Okay, because angina troponin will be normal, but here we will have chest pain even at rest. So that is unstable angina. Okay, then in vasospastic angina, we also called transmittal or variant angina occur at rest due to coronary artery spasm. Okay, here you will when you will have coronary artery spasm, you will have whole artery blockage. So you will have transient ST elevation in ECG. Tobacco is important risk factor, but other like hypertension, hypercholesterolemia, other classic coronary artery disease risk factor will be not present here. Only tobacco is a risk factor here. So what is the pathophysiology of vasospastic angina? Actually, first most important point is it is common in actually night. It is common at night, late night, late night or morning. It is common in that. Actually, here a coronary artery will be sensitive. Like that is called actually question I have been asking you were okay. The pathophysiology of vasospastic angina is similar to Raynaud phenomena. Actually, Raynaud phenomena, you will have a hypersensitivity to cold, stress, or emotion. Okay, same in the scenario. Here, coronary artery are hypersensitive. Reason is that in those type of patients, you will have more at night. You will have more vagal response, and you will have decreased the sympathetic response. And you have more vagal response. Vagus will cause like they can cause vasoconstriction. Okay, that is important point. Okay, so guys, this is important point. Okay, and remember, this type of angina will spontaneous resolution within 15 minutes. Within 15 minutes, it will resolve. Okay, remember this. So what is the pathophysiology? It is a hyperactivity of coronary smooth muscle due to endothelial dysfunction and autonomic imbalance. Actually, autonomic is imbalance, more parasympathetic, decreased sympathetic. It is common in midnight to early morning. Okay, you can also give you can also okay how you actually how you can diagnose this case. You can give intracoronary acetylcholine. Okay, okay. When you give intracoronary acetylcholine, if endothelium is healthy, okay, endothelium will release NO. Okay, you will have vasoconstriction. But in this case, you will have endothelial dysfunction. So that's why you will develop vasoconstriction. So that is a test to diagnose vasospastic angina. There is another test you can give intracoronary ergonovine. Intracoronary ergonovine. That is the serotonin 2 receptor. Act on serotonin 2 receptor. Okay, so that is the same thing. Okay, okay, we have covered. Okay, and then drug are very high yield. Okay, trigger are cocaine, alcohol, triptan have been asked, cocaine have been asked. Okay, so in Prince metal angina, never give these drugs. Treat with calcium channel blocker, nitrate, and smoking cessation. If you know what are the drug for angina, most drug of choice is the beta blocker. Second drug of choice is calcium channel blocker. Third drug of choice is you can give nitrates. So here you are not giving beta blocker. Very important point. You will not give beta blocker in this case because actually you will avoid propranolol. Actually, in those patients you will have increased vagal tone. Okay, that's why when you give beta blocker, actually beta blocker can cause uh, what you can say when you give beta blocker, you can have alpha induced vasoconstriction. Okay, so here you are having autonomic imbalance. So you are blocking you are blocking the beta agonist. But what about alpha? Here you will have more risk of vasoconstriction. So you will avoid beta blocker. You will avoid propanol. Otherwise, guys, in angina, stable, unstable, drug of choice is the beta blocker. So here is MI. Now I will move toward MI. One of them is the STEMI, that is called non-ST elevation MI. This is ST elevation MI. Pain occur both in rest. In both, you are having elevation of troponin. Difference is that here you will have subendocardial ischemia. Here you can see you will have ST depression. In this case, you will have transmural inflammation. You will have ST elevation. Okay, that is difference on ECG. Otherwise, same point. Next is a coronary steal syndrome.